Good afternoon, everyone, and welcome to our third webinar of 2021 in the ACCP Immunology and Transplantation PRN webinar series. My name is Christina Doligalski, and I'm a clinical pharmacist practitioner at UNC Health with a primary practice site in our heart transplant, lung transplant, and LVAD clinics, and it's my pleasure to be moderating today. Today's webinar is entitled The March Transplant Journal Club Trifecta, and we are honored to have three great speakers present to us today. First, we will have Dr. Bailey Weiss, who is a clinical pharmacy specialist in abdominal transplant, covering both inpatient and outpatients at the Ochsner Health in New Orleans, Louisiana. She received her Doctor of Pharmacy degree from the University of Florida and then went on to complete a PGY1 pharmacy practice residency, followed by a PGY2 in transplant at the Medical University of South Carolina. After Bailey, Dr. Spenser January will be joining us. She is a lung transplant pharmacist at Barnes-Jewish Hospital. She completed her PGY1 residency at Henry Ford and then her PGY2 in solid organ transplant at Barnes-Jewish. And then finally, Dr. Ryan Winstead will be closing us out. He is a transplant pharmacy specialist with Virginia Commonwealth University Health. He received his PharmD from the University of Pittsburgh in 2016, and then went on to complete his PGY1 and PGY2 residency training with the University of Kentucky. In a moment, I will turn it over to Bailey to begin the presentation, but here are a few quick notes. If at any point during the presentation you have a question for the speaker, please submit your question by using the chat functionality on the left-hand side of your screen, and please send the question to the presenter group. We will take and respond to those questions after each Journal Club presentation today, so feel free to send any questions as they come up during the talks. There will be an evaluation for this webinar at its conclusion. We encourage you to complete that to let us know how we did and how we can improve our webinars going forward. The slides from today's presentation will be posted on the ACCP website in the section entitled Webinar Slides after the presentation, and the audio will be posted on our PRN YouTube page, which is currently in the works. If you experience any technical difficulties during the webinar that are not fixed by logging off and refreshing your internet connection, please make the presenters aware through the chat functionality. There is also a live chat on the upper right-hand corner of your screen where you can get technical support specifically from any meeting. And with that information, I'm happy to turn it over to Bailey.
All right, thank you for that introduction and for allowing me this opportunity to share our research regarding the impact of pre-transplant opioid exposure on healthcare utilization and cost in kidney transplant. The opioid epidemic has heightened awareness of the detrimental consequences regarding the use and abuse of opioids. Prescription opioid use is responsible for 40% of all the opioid deaths in the United States. Patients with end-stage renal disease often suffer from chronic pain related to their underlying renal disease, comorbid conditions, or disease-related complications. With 40 to 60% of patients on renal replacement therapy reporting pain, many non-opioid pain regimens create concerns for toxicity and are limited in the setting of renal dysfunction. As a result, providers often rely upon opioid-based pain regimens. Unfortunately, when looking at this data in the renal transplant population, recent analyses suggest that opioid use is associated with increased complications, graft loss, and mortality after transplant. When looking closer at some of the existing literature regarding opioid use in renal transplant recipients, multiple studies have reported similar findings regarding the impact on transplant outcomes. Barantes and colleagues was one of the first groups to look into the impact of pre-transplant opioid use on post-transplant outcomes and found that chronic opioid usage pre-transplant resulted in much higher mortality rates compared with patients who did not use opioids 1, 3, and 5 years after transplant. In a follow-up to their previous analysis, Colstretha, Barantes, and colleagues looked at chronic opioid use post-kidney transplant and found that post-transplant opioid use was associated with increased readmissions, however, not mortality or graft loss. Lentine and colleagues have conducted multiple studies regarding pre-transplant opioid use using a national linked registry and pharmaceutical claims database. Through these studies, they found that both complications and mortality were associated with increasing quartiles of pre-transplant opioid use, that opioid use pre-transplant has been the single greatest risk factor associated with post-transplant opioid use and has been strongly associated with graft loss and death, and that post-transplant prescription opioid use in the first year had an even stronger prognostic significance, predicting a twofold increased risk of death and a 68% increased risk of all-cause graft failure during the subsequent year. These findings persisted during 5 years of observation. Abbott and colleagues, too, assessed the effect of opioids on post-transplant outcomes. However, they specifically looked at duration and dosing of opioids, and they found that compared with no or short-term opioid use, that long-term use of opioids, especially chronic high-dose opioids after kidney transplant, was associated with a significant increase in graft loss and death. Thus, given the significance of the outcomes from these recent analyses, and because pre-transplant opioid use has the potential to be a useful real-time risk stratifier for post-transplant outcomes, the aim of our study was to determine the impact of pre-transplant opioid exposure on post-transplant healthcare utilization and cost. Our primary endpoint was the association of opioid use on 1-year readmissions. As for our secondary endpoints, we looked at the association of pre-transplant opioid use on 30 and 90-day readmissions, cost associated with the readmissions at all time points, chronic opioid use after transplant, and we also sought to identify independent risk factors for 1-year readmissions, as well as assess differences in preventability of these readmissions. Our study was a single-center retrospective cohort analysis of kidney transplant patients. We included adult patients who had received a kidney transplant from January of 2010 through December of 2016. Some important definitions to understand for our research was that we defined opioid experience as patients who had active opioid use during medication reconciliation or with an opioid prescription that was filled in the 3 months prior to transplant. Chronic opioid use after transplant was defined by patients that had claims for opioid prescriptions in 3 or more of the 11 months in the year after transplant. However, this did exclude the month after transplant the month of transplant, as patients did receive a prescription at time of discharge. Readmissions were reported by the hospital to the Vizient database and classified by their discharge diagnosis. Preventability was considered to be potentially preventable if there was a reasonable expectation that it could have been prevented, and this was assessed by an independent practitioner. And lastly, costs. We looked at direct costs, and they were determined using a standardized cost definition that's used by Vizient's Clinical Database and Resource Manager. As for our statistics, descriptive statistics were used to compare baseline demographics and transplant characteristics. A Mann-Whitney U-test was used for continuous variables, and a Pearson chi-squared or Fisher-Exact for categorical variables. A multivariable logistic regression model using backward elimination was used to determine which covariates were independently associated with readmission, as well as to identify covariates that were independently associated with chronic opioid use after transplant. This study included 1,129 patients, 24% of which were classified as opioid experienced. Patients in the opioid naive cohort were found to be more likely male as well as African American and have higher functional status. No differences were found between causes of end-stage renal disease, and patients in the opioid experience cohort had significantly higher CPRAs, as well as they were more likely to have experienced delayed graft function after transplant and be on concomitant benzodiazepines. As for our readmissions cost and outcomes, there were no differences between the index hospitalization length of stay and cost between the cohorts. No differences in acute cellular rejection rates at 6 months or 1 year between the cohorts. However, readmissions per patient and readmission costs were significantly higher at 30 days, 90 days, and 1 year in the opioid experienced cohort. When comparing the proportion of patients with 1-year readmissions, 51% of patients in the opioid experience cohort were readmitted at some point, compared with 43% of patients in the opioid naive cohort. As for chronic opioid use after transplant, approximately 29% of the opioid experience patients were found to have chronic opioid use after transplant, compared with approximately 7% of patients in the opioid naive cohort. Indications for readmissions were assessed between each cohort. As for indications for readmissions, they were similar between the both groups, with the majority of readmissions being related to infections, followed by surgical complications. When looking at preventability, there were no differences in preventability of readmissions between the cohorts. As for our predictive models, a multivariable logistic regression model was created using variables that were associated with the primary outcome of readmission at 1 year on univariate analyses, or have historically been demonstrated to be risk factors for readmissions. The final model of best fit included 3 variables. After adjusting for other variables, being opioid experienced and having a history of diabetes were independently associated with 1-year readmissions. Another multivariable logistic regression model was created using variables that were associated with chronic opioid use after transplant on univariate analyses. The final model of best fit included 6 variables. After adjusting for other variables, opioid use prior to transplant, a history of diabetes, and age were independently associated with chronic opioid use after transplant. Overall, our study showed that being exposed to opioids immediately prior to kidney transplant was associated with higher rates of readmissions and costs up to 1 year post-transplant, as well as higher rates of chronic opioid use post-transplant. Our study, to our knowledge, was the first analysis of an opioid-related risk factor that's easily accessible at the time of transplant that has demonstrated a strong independent association with readmissions and healthcare costs. Previous studies have used a variety of methods to obtain data, such as individual interviews and national databases. Our group, however, found it to be most time efficient to identify opioid use by both patient reporting during medication reconciliation and records from a pharmaceutical claims database that is available via the Epic medical record. Capturing this data in the 3 months prior to transplant further allowed us to focus on recent opioid use and eliminate one-time prescriptions, as well as remote use from the time of transplant, which would be less indicative of post-transplant outcomes. Our study further supports and helps clarify the current published literature that pre-transplant opioid use is associated with suboptimal outcomes, as well as supports the association of pre-transplant opioid use with chronic opioid use after transplant. Our study did have multiple limitations. This was a retrospective study in Nature. There were also multiple investigators that were responsible for the collection of data. However, to limit discrepancies, all investigators did follow a standard operating procedure. We unfortunately were unable to utilize a state-driven prescription database, and readmission data was only from within our own hospitals, and thus we may have missed readmissions or healthcare utilization at local hospitals and clinics. Finally, we did not collect and analyze outcomes based on intensity of opioid exposure or specific opioids themselves. In conclusion, recent exposure to opioids prior to kidney transplant was significantly and independently associated with increased readmissions and readmission costs at multiple time points up to 1 year post-transplant, as well as chronic opioid use post-transplant. Pharmacists can play a large role in helping to identify at-risk patients and implementing protocols or individualized interventions to help minimize these suboptimal outcomes. With that being said, I appreciate your time, and that concludes my presentation.
Thank you so much, Bailey. And we will go through all of the questions at the end. So at this point, we will turn it over to Spenser.
Thank you for this opportunity to present our recent research that we published looking at if the choice of acid suppression that patients are giving immediately post-kidney transplant influences graft outcomes. As pharmacists, we're likely aware that some of the long-term data surrounding the use of PPI therapy has recently shown that it can cause unwanted side effects, including chronic kidney injury, osteoporosis, infections such as Clostridium difficile and pneumonia, as well as low magnesium and low platelets. We also knew that acid suppression is commonly prescribed after transplantation of any organ due to the GI irritating effects that can occur due to use of mycophenolate or high doses of steroids. As transplant pharmacists, we're constantly trying to minimize the side effects of our immunosuppression. However, if we look at the complications of long-term PPI therapy from the general population and compare that to the side effects that immunosuppression can carry as well, we do see some overlap, meaning that, are we putting our patients at risk for having potentiated side effects that due to concomitant immunosuppression and PPI therapy. So if we look at our table here, chronic renal insufficiency also can be caused by our use of calcineurin inhibitors. Osteoporosis and fractures can be caused by prednisone, particularly high doses or when used over the course of a long period. Infections can be caused by all of our immunosuppression, and thrombocytopenia also is caused by lymphocyte depleting induction therapy, as well as valganciclovir and antimetabolites. At our institution, we sort of had a natural comparator study already set up because we prescribe acid suppression immediately following kidney transplantation to all of our patients. We will place patients on an H2 receptor antagonist unless they were prescribed a proton pump inhibitor prior to transplant, or if they develop a compelling indication to be on PPI therapy. Our goal is to stop acid suppression once our prednisone is at 5 milligrams per day, where our patients remain at that dose for life. So really our basic research question is that if PPIs are potentially augmenting side effects from immunosuppression, should we be trying to convert those on PPI therapy before transplant to H2 receptor antagonist therapy? This was a retrospective single-center study. For your reference, our typical immunosuppression protocol at our institution is induction therapy with rabbit antithymocyte globulin, Tacrolimus, Myfortic, and prednisone, which we taper to 5 milligrams by post-op day 28. We included patients that were transplanted between 2009 and 2018, and they had to remain on their acid suppression for at least 28 days after transplant. We excluded patients that had a previous transplant besides kidney, or if they had received both a prescription for an H2RA and a PPI post-transplantation at any point. Our primary outcome was a functional outcome because due to the risk of PPI therapy causing renal insufficiency, we really wanted to study the functional outcome of our kidney grafts. And so we chose to look at renal function at 1 year after transplant. And we also assessed renal function at various other time points in the post-transplant course. Because we wanted to isolate the effect of our acid suppression on our outcomes, we only considered patients to be included for the time period that they were on their acid suppression therapy. In other words, we censored our patients once the PPI or H2 receptor antagonist therapy was stopped, or up to 9 years post-transplant, or the time of graft loss or death, whichever came first. Secondary outcomes can be broadly classified into safety, including rejection episodes, need for magnesium supplementation, thrombocytopenia, pneumonia, and Clostridium difficile infections, as well as osteoporosis and fractures. And also we wanted to look at efficacy, namely the incidence of gastritis, GI ulcers, or GI bleeds following transplant. There's some literature suggesting in the general population that poor outcomes are tied to the dose of PPI. And so we also wanted to do a subgroup analysis looking at our patients that were on high doses of PPIs for at least 30 days during their post-transplant course compared to H2 receptor antagonists to see if this would influence outcomes as well. So we studied this subgroup with all of the previous mentioned outcomes too. For statistical analyses, they were pretty straightforward. We did use a logistical regression looking at the development of CKD stage 3A or worse. We used a forced entry model with things that we know can potentially confound renal function, including age, ethnicity, rejection episodes, and incidence of CMV or BK viremia post-transplant. In total, we had 1,287 patients that were included. This was broken down into 705 H2 receptor antagonist treated patients and 582 PPI treated patients. This number predictably decreased over time as patients were censored out of the study due to cessation of their acid suppression or if they had graft loss or death. So that by 9 years, we had 31 patients in the H2 receptor antagonist arm and 80 patients in the PPI therapy arm. Baseline characteristics that were not evenly matched are listed here. All the other characteristics were similar between groups. Our PPI arm was older, more frequently Caucasian, and had higher BMIs. Predictably, our PPI group also had a higher incidence of GI disorders, which tracked very closely with our institutional protocol, again, which is to keep patients on a PPI after transplant if they came in on a PPI. So it makes sense that those patients would have a higher rate of GI disorders pre-transplant. So there were higher rates of Barrett's esophagus, reflux, and GI ulcers in our PPI arm. For our primary outcome, GFR at 1 year was remarkably similar between the H2 receptor antagonist and PPI arm, so both about 60 mL per minute. The other time points that we assessed are listed or shown at the graph at the right, so we do see very closely tracking along with one another all the way really through the end of follow-up at 9 years. By 9 years, you do see a little bit of the deviation of the two lines. However, it was still pretty similar, with H2 receptor antagonist having an average GFR of 70 and PPI arm having an average GFR of 64. And this still did not reach statistical significance. For our logistical regression for the development of CKD stage 3A or worse, when we adjusted for those confounders, there also was no difference in the development of having a GFR less than 60, even when we accounted for known confounders to renal function. Secondary outcomes are listed in this table. There were higher rates of having low magnesium requiring supplementation post-transplant in the PPI-treated arm. We saw very similar rates of infections, including Clostridium difficile and pneumonia between groups, as well as similar osteoporosis rates. There were higher rates of post-transplant GI disorders, including reflux, GI ulcers, and GI bleeds in the PPI-treated arm, which is likely a reflection of the fact that our PPI-treated arm had a significantly higher incidence of these disorders pre-transplant. We also saw no difference in rejection or graft loss. Our high-dose PPI-treated patients compared to H2 receptor antagonist-treated patients, this subgroup analysis did have some interesting findings. Firstly, it was pretty shocking to us to see how many patients actually did receive a high dose of PPI for at least 30 days after transplant. So this was half of our PPI cohort as a whole. For the primary outcome of renal function, this did not differ still when we looked at high-dose PPI versus H2 receptor antagonists. When we look at the secondary outcomes, there was a potential signal for higher rates of biopsy-proven acute rejection in the PPI arm, with about 10.5% of those patients experiencing rejection compared to around 7% of our H2 receptor antagonist patients. And this imparted an odds ratio of 1.65. We broke it down into acute cellular, antibody-mediated, and mixed rejection to see if there was a difference in the type of rejection, and there was not. Because there was not a strong physiological basis as to why our high-dose PPI patients would be rejecting at a higher rate, we wanted to make sure that this was a legitimate signal, and so we did a post-hoc Cox regression analysis where we used high-dose PPI as a time-varying covariate, and we adjusted that model for gender, prior transplant, and induction immunosuppression. And when we did this analysis, the significant difference disappeared between the groups. So although there was a potential signal on the univariable analysis for increased rejection, this did not hold up when we adjusted for other confounders. We did find that the dose of PPI did significantly impact the incidence of pneumonia and osteoporosis. High-dose PPI, when compared to H2 receptor antagonist therapy, imparted a 2.5-fold increased risk of pneumonia and a 2-fold increased risk of osteoporosis. A couple of other notable findings from our study was a surprising amount of patients actually did not have an ongoing indication for being on acid suppression. This was 70% of our PPI patients and about 88% of our H2 receptor antagonist patients that did not have any diagnosis of a GI disorder post-transplant, but were continued on acid suppressive therapy. We also found that PPI therapy did continue significantly longer than H2 receptor antagonist therapy, but that both well exceeded our goal of having acid suppression off by post-op day 30. We found that our PPI arm on average continued this for 5.5 years, and our H2 receptor antagonist arm continued this for 3 years. So this potentially provided us with some insight into the prescribing practices in the more chronic post-transplant setting. Our key takeaways from this study is that the choice of acid suppressive therapy immediately following kidney transplantation, so PPIs versus H2 receptor antagonists, did not significantly impact renal function up to 9 years post-transplant, and this what held true whenever we looked at high-dose PPI therapy. It confirmed previous studies in the general population with respect to high doses of PPI being associated with higher rates of osteoporosis and pneumonia, and that hypomagnesemia is significantly worse with PPI therapy when compared to H2 receptor antagonists. However, we did not confirm something that has been seen in the general population studies, which is PPIs did not cause thrombocytopenia in our patients. So this definitely made us feel a little bit better about using it in the post-transplant setting, given that we're pretty much always worried about thrombocytopenia in our immunosuppressed patients. Some of the takeaways as far as clinical practice changes that can be made based on this study is that we did find that many patients were continued on acid suppressive therapy despite no ongoing indication. And so this potentially gives us a target for pharmacists in the clinic setting to be discontinuing these therapies, especially for those patients on high-dose PPI therapy, since there was a higher rate of osteoporosis and pneumonia with that therapy. This was a retrospective study, and so we did rely on prescription start and stop dates as being accurately documented in the electronic medical record. And we also relied on ICD coding for disease states such as pneumonia, osteoporosis, and GI disorders. While this was certainly the largest kidney transplant study looking at this comparison, by 9 years, our numbers were limited at 111 patients total. So this does kind of limit our conclusions that we can draw from the 9-year data. And there was selection bias because we did continue our patients on PPI therapy if they were on it pre-transplant. That's all I have.
Spenser, thank you so much. We will turn it over to Ryan.
All right. Hello, everyone. Thanks for having me today. For the next 15 minutes or so, I'd like to describe a recent paper we published at VCU entitled Letermovir Prophylaxis in Solid Organ Transplant, Assessing CMV Breakthrough as well as the Tacrolimus drug interaction. I have no conflicts of interest regarding this presentation, but we do discuss off-label use of Letermovir. Before we began this study, we had some questions that arose. So there's the age-old clinical controversy of what you do with leukopenic patients, specifically CMV high-risk patients. Do you suspend their valganciclovir, potentially raising their white count but putting them at risk for CMV infection? Do you help them power through with G-CSF or filgrastim? Or do you reduce their antimetabolite, potentially raising their risk of rejection, as well as the white blood cell count? So none of these options are perfectly ideal. So we looked to see what else we could do to help our patients, leading us to look into Letermovir. As we researched more into Letermovir, we looked at its pharmacokinetics as well as drug interactions. So we had a question of, if Letermovir is a CYP3A4 inhibitor, what do we do with a calcineurin inhibitor? And then lastly, we looked to see if we could replace Letermovir with valganciclovir in specific patients who had risk of leukopenia. So just to begin with some background, solid organ transplant recipients who are CMV seronegative and received a CMV seropositive donor are the highest risk of CMV infection. Patients deemed to be at moderate risk or recipient positive often receive antiviral prophylaxis in addition to their high-risk counterparts. Currently, the most widely used therapeutic agent is the drug valganciclovir. While valganciclovir is effective against CMV, it's often used for treatment as well as prophylaxis. A common adverse effect is bone marrow suppression, and we often see this presenting as leukopenia. Letermovir, however, came on the market several years ago, and it was a novel drug approved for hematopoietic stem cell transplant recipients or bone marrow transplant recipients. Contrary to valganciclovir, which inhibits viral synthesis through phosphorylation, Letermovir inhibits the CMV DNA terminase complex and acts at the end of the sequence. Prescribers and physicians like Letermovir as it does not cause this leukopenia reaction. Specifically in the bone marrow transplant population, this is very appealing, compared to the valganciclovir, which often disposes the patients to this. A potential downside of this medication is the possibility for treatment resistance, as it's thought to have a lower barrier, and a limited and paucity of data in solid organ transplant specifically. For this study, it was single center, and it was a matched cohort study. Our patients were matched manually by the organ transplanted and the CMV risk. This was done in a 2-to-1 manner. So for every kidney transplant that was seen to be high risk, we matched them to 2 kidney transplants who were seen to be high risk based on whether they received Letermovir or whether they received valganciclovir. So we had twice as many valganciclovir patients in the study. We used our heart, kidney, liver, as well as our simultaneous liver-kidney transplant recipients. So any solid organ transplant above the age of 18 who received Letermovir was included. We ended up with 52 patients in the valganciclovir group and 26 in the Letermovir group for the primary outcome. And just of note, all Letermovir patients were converted from valganciclovir, so this is not a de novo study, it was a conversion study. Our primary outcome was the rate of CMV breakthrough, which we defined as greater than 1,000 units per ml for asymptomatic patients, and then any detectable CMV at all in the presence of symptomatic disease. We looked at this at the time of cessation of prophylaxis. So in our high-risk patients, which was the majority, at 6 months, we paused and looked back at any time while they were on prophylaxis to see if they had a CMV, one incidence of CMV PCR positivity or symptomatic disease. Our secondary outcomes were change in GFR, any type of rejection, several different types of infection, including BK virus, bloodstream infections, urinary tract, respiratory tract. We also looked at pharmacokinetic data. So we're looking at the change in tacrolimus dose due to our previous concern of it being a large drug interaction. We also looked at troughs. We looked at change in mycophenolate doses, as well as the white blood cell count change and the platelet change. Regarding data analysis, all categorical variables were analyzed using chi-square or Fisher's exact test where appropriate. Continuous variables were analyzed using a student's t-test or Wilcoxon signed rank test. Any repeated measures, such as our tacrolimus doses, which were measured at times 0, 7, and 30, were analyzed using ANOVA testing, and then the individual differences were looked at using Tukey-Kramer HSD. And then we signified a p-value of 0.05 was considered statistically significant. Now let's discuss the results of this study. I included 2 tables on this slide, so we'll spend a bit of time talking about this. As you can see on the left in table 1, this is our demographic slide. And if you can remember, we did match our patients 2 to 1, 2 in the valganciclovir group and 1 in the Letermovir group. So despite not matching on several of these characteristics, they appeared fairly well balanced at the end. So regarding age, it was nearly identical, with the mean age being 53 years in both. Race was also fairly well balanced. The genders of the patients, it was about 60% male in both groups. The organ group was matched manually, so this should be identical, as it is. Thymoglobulin dose was roughly 5 mg/kg in both groups, and this is only pertaining to the patients who received thymoglobulin, and in this study, it was every kidney transplant recipient. CMV risk was perfectly matched, as this was manually done, and then CPRA was both 0 as the median in both groups. Looking at table 2, getting into more of our outcomes and results, we look at the top of the table, which looks at our primary outcome, so CMV breakthrough. In the valganciclovir group, there was a percentage of 13.5, and the Letermovir group only 7.7%. While visually different, this was not statistically different, so the odds ratio was 0.5, and the p-value is 0.710. So no difference in our primary outcome of looking at CMV breakthrough. And then below this, there are more comparators between the 2 matched cohorts. We looked at infection. We found no difference at all when we looked at overall infection rate. We looked at BK virus. We found no difference. And then we looked at any sort of rejection within the first year post-transplant. We found no difference as well. There was a trend towards significance in the Letermovir group. However, we did not expect this to happen due to the nature of the mechanism of action, but we did include this for completeness sake regarding a transplant study. GFR at the time of cessation of prophylaxis was also not statistically different. This next table looks at our pharmacokinetic data. So we have, on the top, we have the total daily dose of tacrolimus. We looked at this in any patient who was on Letermovir for at least 7 days when comparing the 0 to 7 marks. So there were some of these patients who were not included in the primary outcome, but were included for pharmacokinetic data. So at day 0, the mean dose of total daily dose of tacrolimus was about 9 milligrams. And at day 7, after any dose reductions, the mean daily dose was 5.4 milligrams. We found that our mean reduction was about 3.4 milligrams, and then from day 7 to day 0, there was a statistical difference. By day 30, the mean dose was 3.9 milligrams, and the change from 0 to 30 was also significant. The change from day 7 to day 30, however, was not found to be significant. When looking at the 13 patients who did not have empiric dose adjustments, so we simply had them on a dose of tacrolimus, we added on Letermovir, and we waited to see what happened. This was mostly done in the beginning before we had more clinical background about what would happen, but we do have this reported in this study. So at day 0, our median dose was about 6.4. Again, reporting medians here as the population is less. And then on day 7, the median dose is 16. So we did see a striking increase in tacrolimus concentrations when there was no empiric dose reduction. Then looking at mycophenolate, which while we did not expect a drug interaction, we do expect there to be differences in prescribing patterns based on the leukopenia. So at day 0, our median dose was 500 milligrams, so roughly 250 BID in most patients. At day 30, it was roughly 1,000 milligrams. So patients who were switched to Letermovir were able to increase their mycophenolate dose as their leukopenia has subsided, or at least mitigated. And then the change from day 0 to day 30 was significant. Looking at white blood cell count, at day 0, it was 1.9 a median, and every single one of these patients was converted from valganciclovir to Letermovir for leukopenia. So it does make sense that they would all be leukopenic. And at day 30, 4.5 was the median white blood cell count. So upon discontinuation of valganciclovir, our patients saw an increase in their white blood cell count. And this was again significant with a p-value of less than 0.001. The platelet count was not significantly different. They were both roughly 170 pre and at day 30. I included this image in here just to visually compare the differences in tacrolimus dose at days 0, 7, and 30. You can remember from my previous slide, from day 7 to day 30, there was no statistical difference, but from day 0 to day 7 and day 0 to day 30, there was a difference. So roughly 40% difference by day 7 and 57 by day 30. There are several limitations of this study, one of them being that this was a drug conversion study, not de novo. So every single one of these patients who received Letermovir had initially been on valganciclovir. Additionally, it's a small sample size, so roughly 30 patients in the Letermovir group. Generalizability can be different depending on the study protocol. As here at VCU in our abdominal program, we primarily use valganciclovir 450 milligrams or a mini-dose valsite. So this compared to our heart transplant cohort, which we only had 1 or 2 patients, was 900 milligrams, and several centers also used 900 milligrams. There's also a short follow-up for rejection outcomes. This was censored to the last available data point, leading to very conservative reporting. But again, we did not expect a difference in rejection outcomes. Finally, this was a retrospective study, leading to several limitations on its own, and this would be better reported as a clinical trial, being prospective, which are currently ongoing. So after all this, our conclusions were that patients who were converted from valganciclovir to Letermovir did not show an increased rate of CMV breakthrough compared to a historical matched cohort who remained on valsite. The total daily dose of tacrolimus required for our patients in the Letermovir group was reduced by nearly 40% by 7 days. That's all I have for you today. We'll welcome any questions.
All right, wonderful. Thank you, Ryan. Really appreciate it. Since you presented most recently, we have a couple of questions that have come through for you, and I have some as well, so we can start there. The first question is, were all of the tacrolimus patients in your population, were they on immediate release tacrolimus or an extended release product?
So that's a good question. It was about 2/3 were immediate release and about 1/3 were extended release. So they were all treated the same, but there was a variance in our patients in the group.
Okay. And a similar follow-up question to that, did you consider using or doing TAC dose to trough concentrations to see how that changed as compared to just your doses?
No, that's a good question. At the time of study design, we did not consider this. If we were to go back and do it again, knowing what we know now, I would definitely add that to the analysis, especially now that we've seen such a robust difference in significance in the drug interaction. It'd be nice to repeat it using a different method, but I agree that's a good idea.
Yeah. And, I think that one more follow-up question to that. Anecdotally, or at least maybe in data that you didn't present, did you notice any differences between products for those patients that were on an extended release product versus an immediate release in dose reductions required?
Anecdotally, we did not. We gave them enough time, in our opinion, to see a response. However, we don't know if the metabolism would be different between the products, since we gave them at least 7 days to respond. But it's a good question. We didn't do a subgroup analysis to see if there'd be any difference significantly between immediate release and extended release, but there's a possibility. But anecdotally, we haven't seen that difference.
Okay, that's good to know. The next question for you is, it's kind of a twofold question, both about the breakthrough rate that you saw in your valganciclovir group, as well as something that I've seen clinically in practice with use of Letermovir, which is this low-level DNA-emia that seems to happen in a lot of Letermovir patients, at least that I've taken care of, where they have, 200 to 400 copies per mil, and it just kind of stays there. So I'm first interested to know if you've seen something similarly in your population, and if you have, like, what your approach has been to that, and if that's caused any concern. And then the second part of that being, the rate of CMV breakthrough in your valganciclovir group being 13.5% seems high for a group that's already on it. Do you have any thoughts as to what led to that?
Sure. So regarding the low-level DNA-emia, I do agree we have seen that. You've seen it hover in the low hundreds, like you've said in your experience as well. Initially, it did cause us a bit of concern, but after reaching out to several centers and hearing the same things reported, and then recently published upon, we started to just follow more of a watch and wait. So we'll just follow these patients progressively. We've noticed it only in a select handful of patients, but yes, we have seen that where they just have that low-level viremia. And then regarding your second question about why there's a potentially clinically higher rate of breakthrough in the valpsych group, it's difficult to say. As it was retrospective, it's possible that it was all chance. But one possible explanation could be that there was a impact because of the mini-dose valpsite. So nearly all of these patients were on 450 milligrams compared to 900 milligrams.
Yeah, I was wondering what if you guys had done an analysis of your 450 just overall to look at breakthrough. I know that there are some groups that have reported out, potentially larger body mass or different things like that may contribute to CMV breakthrough in that kind of 450 milligram daily dosing. But that was my initial thought as well. Any other questions? Yes. Oh, hold on. There's one more for you. A couple more actually for you, Ryan, and then we will get to some of the questions for Spenser and Bailey. The first question is, the ideal sample size of 81 patients described in your methodology, was that a power calculation with sample size determination, or was that something else that you're citing there?
Yes, that was a sample size calculation added in the reviewing stages, but initially was not initially considered to do a retrospective nature. But yes, later on we did do a sample size calculation leading to that idealized sample size.
Okay, great. And given the 3A4 interactions for Letermovir, thinking about other common concurrent medications, including statins, have you guys made any empiric dose adjustments to patients that are on statin therapy or other therapies that are CYP3A4 substrates?
So no, that's a really great question. So we have noticed that in data that mechanistically it could increase the concentration of statins. We haven't had too many patients who had any at least phenotypically significant interactions. We haven't noticed any muscle pain or myalgias. So we've done no empiric dose reductions with our statins. But we have been starting to look more carefully at our patients' medication list when prescribing these drugs from this data. For example, we noticed that in the cyclosporin cohort, for example, the drug interaction is not exactly the same as it is in the tacrolimus group. So one of the recommendations actually is to reduce the Letermovir dose in patients on cyclosporin. We've been a little more cautious lately, but we haven't made any empiric dose reductions of statins, for example.
Okay. And then the final question is, have you had any pushback from insurers for outpatient use of Letermovir or any medication access concerns using Letermovir?
Absolutely. So it was a difficulty getting nearly all of these patients on this drug. So there were a handful, maybe a quarter, or probably less, maybe 20%, who we had no issues getting on the drug. The rest, we had to use prior authorizations, appeals of prior authorizations, and then several patients had patient assistance programs as well. So access was a huge issue throughout this, which is why it's not protocolized by any means at our center. And if we do ever want to put someone on Letermovir, it's after a heavy discussion on if it's even possible. So outpatient use is very much inhibited by insurance.
I agree. And, one of the other things that I've encountered, I'm not sure if you've seen this yet, or I've, switched a couple of patients over to Letermovir and everything's fine initially. And then they tell us that there's a, either 90 or 180 day like year limit because of the initial approval studies in stem cell transplant. And so there's duration limitations as well. Which I've mostly run into in my lung transplant population where we're using longer prophylaxis, but that piece is frustrating as well from an access side.
Absolutely.
All right. Thank you so much for presenting your work and for all of the great questions and discussion. I'd like to move on to some questions for Spenser. The first comes from the audience today. Can you tell us a little bit about your approach to minimizing or removing PPIs? I feel like, at least in my practice as well, people clench very tightly to their PPIs. Do you have do you typically discontinue them? Do you taper them off? What has your approach been?
Yes, certainly. I think that we see that as well, where, patients are on this for some reason before transplant, and they're very hesitant to sort of get rid of that after transplant. I think that it depends on, each patient specifically, of course. If they're on a twice-a-day PPI, then it stands to reason they probably have a little bit more of a compelling reason to be on a PPI, such as, past GI bleed or uncontrolled GI issues on a once-daily PPI. And so I think in those patients, our goal would be to titrate to daily and then monitor their symptoms before discontinuing. For those on a daily PPI coming into transplant, our baseline characteristics actually revealed that less than 35% of those patients had a diagnosis in their chart that would of a GI disorder that would mean they needed a PPI. So potentially they had an issue with reflux in the past and they just stayed on their therapy because they were never told to stop it. So in those patients, I think we would be a little bit more willing to discontinue that therapy once their prednisone is at 5 milligrams and they're not having any GI symptoms at that, post-op month 1 clinic visit. And then we would discontinue it and see how they do. While we really didn't identify any consistent adverse effects, with the acid suppression in our article, I think that post-transplant, a lot of patients do struggle with overall pill burden. And so, our hope is that we can look at it from that standpoint and potentially convince our patients that it's okay to at least try it off of a PPI and see if they're able to, live their life without any GI issues, just to decrease the overall amount of pills that they're taking per day.
Yeah, those are all great points. And one of the other questions that I had for you is, I'm not sure if you had this recorded, but what percentage of your patients were on peritoneal dialysis going into transplant as compared to hemodialysis, knowing that many of those PD patients, just from a purely like physical space limitation standpoint, often end up with a good bit of acid reflux that can go away after a successful transplant.
Yeah, it's a really great point. As far as dialysis goes, in both of the arms, we had about 80 to 85% that did come into transplant on dialysis of, some sort, whether that's PD or HD. I did not report out which ones were HD versus PD, and I don't remember that number off the top of my head. But that would be a good thing to look at and consider when we're thinking about reasons that patients would need to be on acid suppression.
And then the final question I had for you, Spenser, is, I think that for those of us who don't like PPIs, I count myself in that camp, considering their OTC status now, and patients can go and just buy a PPI if they would like to. What sort of education do you guys employ with your patients, or do you have with the coordinators to make sure that not only are we capturing folks who are on PPIs because they can get it over the counter, but also, encouraging them to avoid that as their first go-to?
Yes, that's another really great question. We do counsel them when we're doing our education immediately following kidney transplant that, our acid suppression, whether that's a PPI or an H2 receptor antagonist, is really there to protect their stomach more so in the beginning when they're, on those higher doses of prednisone. And once we get down, our hope is that they won't need to continue that for life. So we do sort of preemptively educate that this is something that hopefully will just be short term. As of now, we don't actively counsel on the side effects that can occur with long-term PPI therapy. We do attempt to, do medication reconciliations with them and ask specifically about over-the-counter medications at every time that we touch them in the future, whether that's in the clinic or when they're admitted to the hospital. But as far as, education to the patient, as far as avoiding them in the future or self-prescribing those in the future, that's not something that we actively do. But certainly something that potentially we should, given the potential long-term side effects that have been fairly consistently demonstrated in the general population literature.
Yeah, I agree. It's just so hard when there's so many important things to ask about, right? Like I catch myself when I'm seeing these folks who are, 5 or 6 years out from transplant just for an annual clinic visit, trying to not only, remember that we're going through all of their other physician diagnoses and medications, but then OTCs and lifestyle things, and PPIs are one of those very easy to kind of fall off of the radar things. So it can be really challenging, I think.
Yeah, certainly.
Right. Are there any other questions for Spenser from our attendees? Thank you so much, Spenser. Really appreciate you presenting your research today.
Thank you.
So Bailey, I know that, opioids in our transplant recipients are such a, almost hot topic these days, and what we can do and what impacts they have on patient outcomes. One of the things that you suggested in your conclusions is that pharmacists can play a role in minimizing some of these outcomes when we do have that patient that presents to us who has recently been using opiates. So I'm wondering what practices you might recommend, or if maybe there were any practices that you guys were able to implement or change at MUSC to address those patients who did present with opioid exposure, to help mitigate some of the increased healthcare utilization that you saw.
Hey, yeah, that's a great question. So I'm no longer at MUSC since that was conducted during my residency year, but they actually have gone about changing their practice. And from the little that I do know, I think that they've significantly decreased the amount of opioid use by using more multimodal pain approaches. So I think as pharmacists, and something that we're currently doing at my center at Ochsner, is that we're really just stepping in to help educate on what are those different multimodal approaches. So from the surgeon standpoint, using things like pain blocks in the OR, as well as from a post-transplant standpoint, being able to use things such as Lyrica or gabapentin or other muscle relaxers does help limit some of that opioid usage. And I think, too, it's also a matter of education because it's a practice change and sort of setting a different expectation and standard. So being able to get your team on board in the pre-transplant setting to set that expectation, and then educating the nurses on the floor to, not necessarily take the easy route and, give patients opioids when they state that they have pain, to really sort of teach them how to evaluate that pain and how to better approach their care. So those are sort of the approaches that we've taken, but I know MUSC with their practice changes has started to publish on some of the great outcomes that they've seen.
Thank you so much for that. I think that it's definitely something I know I struggle with when I have someone who comes in and, they've they're just that, oh, I've got chronic back pain, but my PCP's been managing it. And then how do you manage their postoperative pain on top of that, and then getting them back in for that chronic pain management can just feel really fragmented and challenging to tackle. Are there any things with your study, Bailey, that if you had the opportunity to go back and either add another analysis or collect another piece of data that you wish you had done?
I think it would be interesting to, I know really the aim of our study was to look at this from a really realistic standpoint so that it could be reproducible at other centers, because we know that we have limited time as pharmacists and there's a lot going into play in these evaluations and post-transplant care. But I think being able to really go in and see the difference in the opioid usage and kind of get a more in-depth analysis of how high of a dose, where their pain was coming from, and kind of understanding may have been more helpful to sort of stratify that risk and see the different outcomes in those groups. Because as you said, it's a tough topic to broach and difficult to have significant changes immediately in kind of approaching these patients.
Yeah. Wonderful. Thank you so much for presenting your work. And thanks to everyone for your time and your attention today. Had a great group. And we will close out the webinar now. Thank you.